I have chapter 30. This is the review on asthma. So, hey guys, this is the review on asthma. So, asthma is a chronic disease of reversible airway obstruction that occurs intermittently. It reduces airflow. I'm sure we all know someone with asthma. So, it is caused by inflammation or airway tissue sensitivity. So, also note that it has a much higher risk of death in older patients. And when it's well controlled, the airway changes are temporary. But if it is not well controlled and happening a lot of asthma attacks, it can actually damage the airway. So in patients with allergies, you're going to see a higher IgE level whenever we're looking at labs. And for allergies, they can do diphenhydramine, Benadryl, the antihistamine, or they can do if it's caused by leukotrienes, then they can use montelukast. And I guess just depending on what is triggering the asthma, they'll choose which one the doctor thinks is going to work best. Triggers can be anything, really. I mean, I have asthma. Mine is triggered by dust and trees and all kinds of things. So, but NSAIDs, aspirin, GERD, animals, dander, yeah. For asthma, it's classified by how well it's controlled, and there's a chart in our book for that in chapter 30. And then symptoms are going to be dyspnea, chest tightness, coughing, an increase in mucus production, and wheezing. And their respiratory rate is going to go up for patients who've had it for a long time and it's poorly controlled. You see barrel chest. And people, when they're in the throes of an asthma attack, are also going to have a really difficult time talking. So they're going to have a really hard time explaining to you what's going on. For a severe attack, that is going to involve hypoxemia, and then you're going to want to look for cyanosis and tachycardia, changes in consciousness and cognition, and then you can do ABG levels, and then we are also going to look at pulmonary function tests, specifically the FVC, the FEV1, and the PEF. Those are all explained in the book too. I'm not going to get too much into those, but treatment is basically, our goal is to control and prevent asthma attacks. So we want to teach our patients to keep a journal. That way we can try to figure out what's triggering their asthma attacks. And so they can keep a journal as to when they need to use their rescue inhaler, what they were doing, where they were, what made it better, and then like, for example, when we found out that my asthma was triggered by dust, we ended up getting the allergen covers for all of our pillows, our mattresses, and we have an air purifier in our room and with a HEPA filter. And then we would like to get rid of the rest of our carpet. So just depending on whatever causes it, And then for the this is mostly going to be for, I guess, patients that have a hard time with controlling their asthma. They are going to have a peak flow meter. I've actually never had to use one, but I mean, I've done PFT testing, but I don't have any of that here at my house. So there's a picture of it in our book, figure 30-4. And if it is 80% to 100%, then that's green. And then if it is 50% to 80%, that's yellow. And then if the peak flow meter is 50% or below in the red zone, then they need to use their rescue inhaler, and then they need to um, go for emergency treatment. So as far as oh, and also after they use their inhaler, like let's say they're in the yellow zone and they use their inhaler, they need to use their peak flow meter a second time to reassess and make sure that it's improved. So as far as prescriptions, there's rescue drugs like the albuterol, that's a fast acting or a short acting beta agonist. And we need to teach them to always use their inhaler, or not always use it, always keep it with them. And then metered dosage inhaler teaching. So this is my inhaler. So this is an albuterol sulfate. So it's got a little counter on it. You can see it. This is a one I just picked up from the pharmacy. So it's got 185 puffs left on it. This is actually really nice. My old inhalers didn't have that when I was a kid. So this is a lot nicer. So this is the outer cartridge, I guess. You want to make sure that they clean this. So I don't clean mine every day. I clean it maybe once a week. But they just need to run hot water through it and keep it clean. And if they've been sick, they need to clean it too. And they can use a the tube thing. I don't use that. I've never used that. The thing that attaches to it. My brain is so fried. But anyway, they can use that to keep the medication in their lungs longer. And you want to make sure when they inhale it that they are breathing in when they inhale it so that the medication goes into the lungs. If they're not breathing in, they're just going to spray it in their mouth, and that's not terribly helpful. So they need to breathe it in once, hold it. I think our book says 10 seconds, wait a minute, and then do a second one, a second inhalation. So my inhaler actually works pretty well. So for me, I only have a rescue inhaler, and then I take an allergy pill every day. But I have used a couple of these other drugs in the past. They can use preventative drugs that are the long-acting beta agonists. That's going to be the formoterol and the salmeterol. But those have a black box warning, and there's an increase in asthma deaths with those medications. So that's in our book. Also, they can try cholinergic agonists. So those are going to block the parasympathetic nervous system. That's going to be your ipratropium and your tiotropium. Spiriva is the one we usually know it as. And we can also try anti-inflammatories, corticosteroids like the budesonide, and then exercise for exercise therapy. If they are going to exercise, they need to keep their inhaler with them too. I use mine before I exercise and after I exercise. But also another important thing is to make sure that they know their inhalers can be affected by the temperature. So if it's really, really cold outside, my rescue inhaler will not work if it's too cold or too I've actually never tried it when it's too hot, but um, if I leave it in the car accidentally, when I get in the car in the morning, if I need it, it won't work. So you need to keep it on them or have multiple inhalers throughout their house. Let's see what else. Oh, they can also use. I have a prescription for albuterol for my nebulizer. So it comes in a big box. And it's in these little packets. And it's a little vial. So my nebulizer is downstairs. So, but it looks like this. So the albuterol is the liquid that's inside of this, and it just pops off. And you twist off the cap and pour it into the machine in the little cup thing, and then inhale it till it's gone. And I only use this when it is like I'm really sick, or if I have run out of allergy pills, whatever. But it's time consuming, so I usually use my RSD inhaler. But very handy to have that. So you may have to teach your patients to use a nebulizer. The other really big thing is you need to calm your patients down. If they're having an asthma attack, it's really easy to panic, especially kids, because you feel like you're drowning. I think in our book they call it air hunger, and once you start to panic, it gets worse. So do whatever you need to do to try to get them to calm down, because they need to really focus on their airway, and it's hard to do when you're panic stricken. So, but we need to look out for status asthmaticus, and that's a medical emergency because it doesn't respond to usual therapies, and it can lead to pneumothorax or cardiac or pulmonary arrest. And as far as treating that, we're going to push epi, IV fluids, and systemic bronchodilators, steroids, oxygen, and possibly magnesium sulfate. Magnesium sulfate is fantastic because it's basically nature's muscle relaxer. So that's a really, really cool thing. And then if they don't have any breath sounds, they're going to get a trach. So hopefully we don't see that, but it happens. So I've never had one that bad. Yeah, so another thing they can do is, I don't know if this is in our book or not, but my asthma improved astronomically when I stopped eating dairy. So they can have food triggers as well as, dust and dander and elm trees and all that stuff. But that's pretty much it for asthma. If anybody has any questions, I have asthma. I know a couple other people in class have asthma too. So I know any of us are always happy to answer questions. Another thing is make sure your patients rinse out their mouths when they use their inhalers, because that can lead to thrush, and we don't want that. So they just need to rinse their mouth after they use it and keep it clean. I think that's pretty much it. So, all right. Thanks, guys.